Welcome. This is Module 2 of the 6 modules that we're covering. We're in this presentation of pharmacological management of the pediatric pulmonary patients. In Module 1, we covered the introduction to pharmacology and pediatric dosing. In number 2, today we're going to cover cardiovascular medications. And next time we're going to cover Module 3, diuretics, followed by the respiratory drugs, and Module 5 will be antibiotics, and number 6 will be sedation. Module 2 begins with a review of cardiac physiology and fluid balance, as well as the determinants of cardiac output. Okay, there are 14 areas in this second module. The list includes the following: methods of deduction, cellular environment, cellular homeostasis, tissue ischemia, adenosine, atropine, epinephrine, and lanoxin. Continuing on in Module 2, the next slide talks about indomethacin, prostaglandin, dobutamine, dopamine, nitroprusside, and finally priscoline. So we'll be talking about each of these drugs in the second half of the presentation. In this limited period of time, for this in-service, like an iceberg, we can only cover the content above the surface. Please do additional research on your own. Sherlock Holmes is a fictional detective, famous for his astute logical reasoning, his ability to adapt almost any disguise, and to use forensic science skills to solve difficult cases. Today, we refer to that as critical thinking. Just like Sherlock Holmes, respiratory care practitioners are encouraged to use the techniques of a consulting detective to be an effective bedside respiratory therapist. Cellular homeostasis. An optimal cardiac output is required to maintain cellular homeostasis. If cellular homeostasis is not maintained, the body cells will die. Every organ plays a significant role in the maintenance of cellular homeostasis. If one organ fails to function, all the body cells will begin to die. As long as the fluid environment in the cell contains the appropriate amount of glucose, fats, proteins, and oxygen, as well as other substances, the cell will thrive. In cellular homeostasis, two things occur. First is the regulation of body water and various substances. The imbalances in the amount or concentration of chemicals in the body occur in many diseases. Secondly, biochemical processes are sustained. The nature and importance of body fluids and electrolyte requires an understanding of physiologic chemistry. The cellular environment is really determined by the amount of fluid that is in the body. Now, the size of the fluid compartment, as you see on the cell, 7% of body weight is mineral, 15% is fat, 18% is protein, a related substance, 60% of body weight is water. there are forces that control where the water goes. Hydrostatic pressure within the vascular is anywhere between 33 and 35 millimeters of mercury. Oncotic pressure is anywhere between 10 to 28 millimeters of mercury, with a net difference of approximately 5 millimeters of mercury. Now, the lungs are a low-pressure system, and the systemic part of the body, high-pressure system. If the hydrostatic pressure increases, whether in pulmonary edema or congestive heart failure, then the net pressure difference will increase, and so fluid will then respectively either go into the lungs, in the case of pulmonary edema, or into the surrounding tissue in the case of left or right congestive heart failure. Respiratory therapy is a science. Frank Starling's equation for fluids in the vasculature is depicted on the next slide. Now, what I've given you is a definition of the various symbols relative to Starling's equation. On this next slide, you'll notice that there's a difference between the hydrostatic pressure and the oncotic pressure. So, the net pressure difference, that's the QF, is the difference between hydrostatic minus oncotic. At the cellular level, you will notice that on the left-hand side there's the cell, in the middle the interstitial space, and on the right the capillary. So again, 33 to 35 for the hydrostatics pressure, the oncotic pressure 10 to 28, and the net difference, the left-hand side, is approximately 5 millimeters of mercury. We talked about the hydrostatic pressure. We talked about oncotic pressure, that the hydrostatic pressure is what goes to the cell. So, given all of those fluids, perfusion is content times cardiac output, and the Fick equation, the VO2, the equation of life, is cardiac output times the difference between CaO2 and CVO2. If we rearrange the Fick equation, then that gives us the amount of oxygen that's delivered to the tissues. So the DO2, the amount of oxygen delivered, is content times cardiac output. So we talked about fluids in the vasculature. Now, Starling's law of the heart. Starling actually has two laws, one of contractility and the other of fluids. So his second law relative to contractility says, and I'm reading from the slide, the greater amount of blood volume preload into the ventricle of the heart during diastole, the relaxed phase, and the greater the volume ejected is during systole or the contraction phase. In regard to Starling's law, then, our goal as respiratory therapists are to increase the preload, that's the amount of fluid that's available to the heart for contraction, the afterload, the amount of forces to contraction, and to optimize cardiac output. Okay, so preload is ventricular volume that is available for eventual ejection. When we look at preload, we're looking at a volume of fluid that is available for ejection, the end diastolic volume. And you can see on the slide that it's the amount of fluid that is actually filling that glass container. When we look at this slide, in addition to the preload, we see two other important elements. First, ionotropy. Ionotropy is the contractility. And afterload. Afterload are the forces resisting ejection of the fluid. So it's much like a wave in the ocean. The preload, the increase in the end diastolic volume, in other words, as the wave washes ashore, is the amount of fluid available for ejection, and the increase in volume of fluid to fill the left ventricle. The two depictions of the hearts, if you'll notice the arrows, the preload is the contraction, and now it's expanding to allow fluid to enter the right and left side of the heart. Again, by definition, we said that preload was the amount of fluid available for entry into these chambers. On the second slide, afterload, you'll notice that relative to the contractility, now it's the red and blue arrows are trying to get fluid out. And if you'll notice in the artery, you'll notice that there are arrows that are causing resistance. So the afterload is the resistance encountered to ejection. Here again, venous, you'll see on the right-hand side of the slide, is the increase in the preload. Look at the area that is serviced there, and the amount of fluid available for ejection. And then on the left-hand side, the decrease in the afterload, the forces encountered to ejection. Or stating it a different way, using a different picture, the decrease in the afterload, the forces encountered to ejection, and you'll notice that now the forces encountered, the little stream which depicts the aorta is smaller, has a smaller lumen, and so therefore increases the resistance, and that's termed the afterload. Graphically, what we're looking at is first on the vertical axis is the stroke volume, and on the horizontal axis is the ventricular end diastolic volume. As the ventricular contractility decreases, stroke volume decreases. The ventricular end diastolic volume increases, resulting in congestive heart failure and possibly cardiogenic shock. And you can see that down by D. A statement in the physiology: the strength of the heart's systolic contraction is directly proportional to its diastolic expansion, with the result that under normal physiologic conditions, the heart pumps out of the right atrium all the blood returning to it without letting any backup in the venous system. Frank Starling's law of contractility dictates that the direction and rate of fluid that transfers between blood plasma and in the capillary and fluid in the tissue spaces depends on the hydrostatic pressure on each side of the capillary wall, on the osmotic pressure of filtering membrane. As the stroke volume decreases, the vertical axis, and as the ventricular and diastolic volume decreases, horizontal axis moves to the left. The patient then slips again into cardiogenic shock. So if we follow A, we have normal cardiac contractility during exercise, running, etc. B, resting. C, as the contractility worsens, the patient then slips into heart failure. And D, worsening of that is cardiogenic shock. Continuing on the next slide, and again, the orientation is the same. As the ventricular performance decreases, and as the stroke volume decreases, the vertical axis, and as the vertical and diastolic volume decreases, the horizontal axis moves to the left. The patient then slips into pulmonary edema, dyspnea, and again in cardiogenic shock. The edema formation is, as we talked about earlier, number one, the first bullet is either an increase in capillary pressure. The precapillary arteriole autoregulates capillary pressure. Therefore, increases in capillary pressure are generally due to an increase in venous pressure, either caused by venous obstruction, e.g., venous thrombosis, and the second is expanded venous blood volume, e.g., heart failure or kidney failure. The second bullet is or the decrease in plasma oncotic pressure. Hypoalbuminemia, generally less than 2 grams per deciliter, normally it's 4 to 5 grams per deciliter, can be seen with nephrotic syndrome and liver failure. So, Starling's law of fluids, a decrease in cardiac output, causing an imbalance of Starling forces, i.e. increase in pulmonary capillary hydrostatic pressure, secondary to elevated pulmonary venous pressure, the decrease in the plasma oncotic pressure, an increase in the negative interstitial pressure, idiopathic or unknown mechanisms which produce this, or producing an alteration in capillary pressures. So therefore, given that kidneys are normal, fluid intake is normal, we usually take in about 2.5 liters over a 24-hour period, and we usually get rid of 2.5 liters over a 24-hour period. There are laboratory tests that can be performed that we could recommend to determine hydration status. The first one and easiest at the bedside is the intake and output, as we have previously covered. The next is hematocrit hemoglobin. Usually hematocrit is 45, somewhere in that area, and hemoglobin usually is around 15. So that gives us the 3-to-1 relationship. Serum sodium is usually 138 to 142. Normal creatinine for the next one is 0.8 to 1.2. And the BUN, usually it's 20 times. Again, a 20-to-1 relationship. Serum osmolarity, skin turgor. This is something that we can assess at the bedside by just looking and pinching the patient's skin. The pulse rate and intensity, something that we can do at the bedside. Does the patient have a rapid pulse rate, a thready pulse rate? And finally, urine osmolarity. To be a consulting detective, the respiratory therapist must be able to assess the patient's hydration status. This is extremely important to us. The next slide is the monitoring of arterial pressures. Here we have the insertion of a Swan-Ganz catheter, where as we move from left to right, we have the right atrial pressure, usually minimal, 3 to 5 millimeters of mercury. Right ventricular, usually up to 30 millimeters of mercury. The right atrial pressure, usually 25/10. And then the pulmonary capillary wedge pressure. But we can only get accurate pressures if we have preloaded. What we're looking at in front of you is a schematic of the fluids as they're administered. And so we start at the top where we have the trachea, we have the branching to the right and left side, right and left lung. Those are the alveoli there. And then as we move now to the left atrium, the left ventricle, ejecting down the arterial system, down to the cell. Once sufficient fluid has been administered to reestablish the extracellular fluid, then this is a schematic of oxygen delivery to the cell and the removal of CO2 from the cell. And finally, this cell depicts the gas exchange at the tissue level, the unloading of oxygen, the removal of carbon dioxide from the cell to preserve cellular homeostasis. The first half of this presentation began with reviewing cardiac physiology, fluid balance, the determinants of cardiac output, heart rate, preload, afterload, cardiac contractility. Now we're ready to review the cardiovascular medications in the treatment of shock, and then the importance of establishing and maintaining cellular homeostasis. Then finally concluding with the cardiovascular medications. Let's move on to cardiovascular medications. The determinants of cardiac output, stroke volume, there you see the heart rate, preload, afterload, cardiac contractility. Now that we reviewed cardiac physiology and fluid balance and the determinants of cardiac output, which are the heart rate, the preload volume, the afterload resistance, and the cardiac contractility, we can now discuss cardiovascular medications in the treatment of hypotension. Hypertension, and more severely shock, have 7 causes. and the 7 causes of shock, and shock is defined as tissue ischemia. We have anaphylactic shock, cardiogenic shock, hypoglycemic or diabetic shock, hypovolemic or hemorrhagic shock, neurogenic shock, psychogenic shock, and finally, septic shock. As a clinician and a consulting detective, the signs of hypotension leading to tissue ischemia are manifested by tachycardia and cold, clammy sweats. So now we've primed the pump. Patient has been given sufficient fluids, so we are now prepared to administer the cardiovascular medications. The cardiovascular medications will be limited to pediatric critical care drugs. As a respiratory therapist, to be an effective clinician at the bedside, I suggest you strive to continue to become a consulting detective, drawing large conclusions from the smallest observation. In that vein, please become familiar with the EKG tracings, the patient's hemodynamic status, the mode of action of the patient's medications, the therapeutic dosage, and, most important, the side effects of the medications. Supraventricular tachycardia. In general, STV are caused by 2 separate mechanisms. The first mechanism to cause SVT is re-entry. The second mechanism is automaticity. SVT due to re-entry, such as AV nodal re-entry tachycardia and atrioventricular reciprocating tachycardia, often present with sudden, almost immediate onset with a sudden increase in heart rate. A person experiencing PSVT may feel their heart rate go from 60 to 200 beats per minute almost immediately. Typically, it is also the sudden termination from the fast heart rate to normal rhythm. Wolff-Parkinson-White syndrome is a combination of SVT with the characteristic findings on EKG. Although technically an SVT can be due to supraventricular cause, the term is often used by clinicians to refer to as one specific cause of SVT, namely paroxysmal supraventricular tachycardia. SVT is the most common due to a loop of electrical current in the heart, which, as it loops, causes the heart to beat quickly. 2 common types of SVT are atrioventricular reciprocating tachycardia and AV nodal reentry tachycardia. In older adult patient populations, atrial fibrillation becomes one of the most common types of supraventricular arrhythmias. Though this is typically considered separate, SVT is generally not threatening, and it may not cause a worsening of heart function if it is sustained for hours. The next slide is a tracing of supraventricular tachycardia. It is a rapid heart rhythm originating from the ventricular tissue. Supraventricular tachycardia can be contrasted to the potentially more dangerous ventricular tachycardia, rather rapid rhythms that originate within the ventricular tissue. You'll notice the absence of P waves. Adenosine is an active metabolite of adenosine triphosphate. Moving on the next slide is a graphic representation. Adenosine plays an important role in the biochemical process, such as energy transfer, ATP, into adenosine triphosphate, and signaling transduction as a cyclic adenosine monophosphate, CAMP. Adenosine is indicated for the treatment of sustained paroxysmal supraventricular tachycardia, SVT. Adenosine is an antiarrhythmic, and it converts paroxysmal supraventricular tachycardia to normal sinus rhythm by slowing conduction through the AV node and interrupting the re-entry pathway. Adenosine's action consists of depressing sinus node automaticity and AV conduction. Response is expected within 2 minutes of the dose. Hemodynamically, the intravenous bolus dose of 6 to 12 milligrams of adenosine usually has no systemic hemodynamic effects. When the larger doses are given by infusion, adenosine decreases blood pressure by decreasing peripheral resistance. Adenosine slows conduction time through the AV node, can interrupt the re-entry pathways through the AV node, and can restore normal sinus rhythm in patients with paroxysmal supraventricular tachycardia, including PSVT associated with Wills-Parkinson-White syndrome. Adenosine is antagonized competitively by methylxanthines such as caffeine, theophylline, and potentiated by blockers of nucleoside transport. So, adenosine slows the conduction time through the AV node, and adenosine is not blocked by atropine. While the majority of individuals with Wills-Parkinson-White syndrome remain asymptomatic throughout their entire lives, there is always the risk of sudden cardiac death associated with the syndrome. Severe sinus bradycardia. Sinus bradycardia is a sinus rhythm of less than 60 beats per minute. It is a common condition found in both healthy individuals and those who are considered well-conditioned athletes. Bradycardia is not necessarily problematic. People who regularly practice sports may have sinus bradycardia because their trained hearts can pump through enough blood in each contraction to allow a low resting heart rate. Look for the P waves. The decreased heart rate can cause a decreased cardiac output, resulting in symptoms such as lightheadedness, dizziness, hypotension, vertigo, and syncope. The slow heart rate may lead to atrial, junctional, or ventricular ectopic rhythms. Atropine. Atropine is used in the reversal of severe sinus bradycardia, especially in the presence of parasympathetic influence, such as drugs and carotid sinus reflex. This will be tested on post-test question number 6. Atropine is an anticholinergic drug. As such, it plays a parasympathetic receptor, reducing the stimulation of the parasympathetic branch that causes the bradycardia. Atropine is a muscarinic receptor antagonist. The vagus parasympathetic nerves innervate the heart. The release of acetylcholine as the primary neurotransmitter increases vagal activity to the SA node, decreases the firing rate of the pacemaker cells. Epinephrine is used during resuscitation for the treatment of acute cardiovascular collapse. It may be used either as a short-term treatment for cardiac failure that is resistant to other drugs. Now, again, no P wave. If you look at the tracing, a circulatory collapse is defined as the general or specific failure of the circulation, either cardiac or peripheral in nature. Although the mechanisms causes a clinical syndrome are different, the pathogenesis is the same. The circulatory system fails to maintain a supply of oxygen and other nutrients to the cell and to remove carbon dioxide and other metabolites from them. The failure may be hypovolemic and distributive. Acute cardiovascular collapse. A milder or preliminary form of circulatory failure is circulatory insufficiency. A common cause of this could be shock, trauma from injury, or surgery. A general failure is one that occurs across a wide range of locations in the body, such as systemic shock after the loss of large amounts of blood, collapsing all the circulatory systems in the legs. A specific failure could be traced to a particular point, such as a clot. The effects of a circulatory collapse vary on the type of collapse it is. Peripheral collapses usually involve abnormally low blood pressures and result in collapsed arteries and or veins, leading to oxygen deprivation to tissues, organs, and limbs. Acute collapse can result from heart failure and cause the collapse of primary vessels in the heart, collapsing, if you will, combining with cardiac arrest. One of the drugs that we do to restore cardiac rhythm is epinephrine. Epinephrine restores cardiac rhythm in cardiac arrest in the absence of ventricular fibrillation and attacks the transitory atrioventricular heart block with syncopal seizures. It stimulates the alpha and beta receptors, alpha at higher doses, beta 1 and beta 2 receptors at moderate doses within the sympathetic nervous system. Additionally, epinephrine is used subcutaneously in the treatment of acute bronchospasm. In the next group of drugs, we need to know the terminology. The terminology is, first of all, by definition, entropic, increases the contractility of the heart muscle, chronotropic, slows the heart rate, and dromotropic, decreases the conductivity of the current in the cardiac nerves. So, in these drugs, we have a positive inotropic response. In other words, it increases the contractility. It decreases the rate. It's a negative chronotropic, and it decreases the conduction, a negative dromotropic. The first in this group of drugs is digoxin or lanoxin, and again, a positive inotropic, increases the contractility of the cardiac muscle. A negative chronotropic slows the heart rate down, and a decrease in the dromotropic decreases the conductivity of the current across the cardiac nerves. Digoxin is a cardiac glycoside, and is used to regulate and strengthen the heart rate. It increases the forces of velocity of myocardial contraction and prolongs the refractory period of the AV node by increasing calcium re-entry into the myocardial cells and slows conduction through the sinoatrial and the AV node. And it produces an antiarrhythmic effect. So, digoxin is indicated in the use of atrial fibrillation, atrial flutter, paroxysmal atrial tachycardia, cardiogenic shock, and all degrees of congestive heart failure. Patent ductus arteriosus is a condition in which the ductus arteriosus does not close. The ductus arteriosus is a blood supply that allows blood to go through the baby's lungs before birth. Soon after the infant is born and the lungs fill with air, the ductus arteriosus is no longer needed. It usually closes in a couple of days after birth. PDA leads to abnormal blood flow through the aorta and the pulmonary artery, two major blood vessels that carry the blood from the heart. Symptoms that the baby usually feels are rapid breathing, poor feeding habits, rapid pulse, shortness of breath, sweating while feeding, tiring very easily, and poor growth. Indomethacin is indicated to close hemodynamically significant patent ductus arteriosus. Indomethacin is a non-steroidal anti-inflammatory drug. Prostacyclin chiefly prevents the formation of platelet plugs involved in primary homeostasis as a part of blood clot formation. It is also an effective vasodilator. It does this by inhibiting platelet activation. Prostaglandin E1, also known pharmaceutically as alprostadil, has vasodilating properties. Alprostadil is indicated to maintain the patency of the ductus arteriosus until corrective surgery can be performed. The last group of drugs in the management of congestive heart failure are dopamine, dobutamine, and nitroprusside. Dopamine is a sympathomimetic drug used in the treatment of heart failure and cardiogenic shock. This is covered in post-test question number 8. Its primary mechanism is direct stimulation of the B1 receptors of the sympathetic nervous system. And that is going to be tested on post-test question number 9. Dobutamine is indicated for short-term treatment to increase cardiac output due to decreased contractility from organic heart disease or cardiac surgical procedures. Dopamine is a simple organic chemical in the catecholamine family. It's a monoamine neurotransmitter which plays a number of important physiologic roles. In addition to being a catecholamine and a monoamine, dopamine may be classified as a substituted phenylethylamine. Dopamine is indicated in the correction of hemodynamic imbalances present in shock syndrome due to a decrease in cardiac output function, in congestive heart failure, endotoxin septicemia, renal failure, and myocardial infarction. Dopamine is a positive ionotropic effect and on the myocardium, and it also has an alpha and beta adrenergic agonist effect, sympathomimetic. Nitroprusside. Nitroprusside is a vasodilator. It's an antihypertensive. The action interferes with calcium influx and intracellular activation of calcium, causing peripheral vasodilatation and direct blood pressure decrease. So, sodium nitroprusside, abbreviated SNP, a brand name Nitropress, has a potent vasodilating effect on the arterioles and the venules. It is administered intravenously in cases of acute hypertensive emergencies. Prescaline. Prescaline is indicated for the treatment of persistent pulmonary hypertension of the newborn. Treatment should only be started when the arterial oxygen cannot be maintained by oxygen and or mechanical ventilation. Prescaline treatment should be started when arterial oxygenation cannot be maintained in order to maintain cellular homeostasis. Prescaline also has been used successfully as an antidote to reverse severe peripheral vasoconstriction. Prescaline is a non-selective competitive alpha-adrenergic receptor agonist. It is a vasodilator that is used in the treatment of spasms of peripheral blood vessels, as in acrocyanosis. Acrocyanosis is a condition marked by symmetrical cyanosis of the extremities with persistent, uneven, molted blue or red discoloration of the skin of the digits. Summary. The role of the respiratory therapist is that of a consulting detective, drawing large conclusions from the smallest observations and critical thinking. It is extremely important for us and our profession and your function in our profession to develop your skills of following the smallest observations, identifying the smallest observations. Remember the Fick equation, the equation of life. In conclusion, in order to stay on the cutting edge as a professional respiratory therapist, please cultivate your own methods of assessment, skills, critical thinking, and powers of deduction, and strive to work as a consultant detective. Thank you very much.